Okay, good evening, everybody. It is 6:30 on the dot, so we will get started. I'm Dr. Jennifer Wessels. I'm a family medicine physician in St. Louis, and I'm really excited to announce that we have tonight Dr. Russell Cole here to present our newest teammate, Integrating Artificial Intelligence into Family Medicine. Tonight's presentation is delivered live, and our presenter is going to be available to us for questions immediately following. Feel free to drop questions into the chat as they come up through the presentation. I will moderate those at the end of the session today, and I will bring those forward to our speaker. If you would like to ask questions directly at the end of the presentation, you're welcome to take yourself off mute and ask questions directly to Dr. Cole. Participation in tonight's presentation is qualified for 1 CME credit. This session is being recorded and it will be uploaded to MAFP's YouTube channel for your future reference. CME, though, is only available to those who are in live attendance. Please also remember to complete the short survey. Bill is going to send that link out in the chat, and he also sent it out in today's reminder email. Information there is going to be entered to report your CME over to the AAFP. Also, as a reminder, this is our 6th of our 10 sessions that MAFP has planned to deliver us great and convenient interactive CME. We also have some wonderful sessions coming up later on this summer and early fall. In August, we have our 2023 CDC update, HIV positive birthing persons and the provision of human milk. That'll be on August 15th. Value-based care for family physicians, and that will be on September 19th. And finally, primary care dermatology in Skin of Color on October 17th. So if you find these sessions as convenient and informative and fun as I do, please remember to nudge your colleagues into registering so that they can attend with you. And if you love in-person CME, we really look forward to seeing you all at our annual fall conference, and that will be in November. This year, we'll see everybody November 7th through the 9th on the Plaza in Kansas City. Registration is now open. So without further ado, we would love to welcome you, Dr. Cole.
Great, thank you. I certainly appreciate it. And I'll start off with an apology that I was supposed to be in a very nice, quiet, either hotel room or conference room, but as modern travel is going, my flights are about 2 hours behind. So I am sitting instead in what appears to be the world's loudest Starbucks. So I apologize for any background noise, but I think we can make this work. So by ways of introduction, my name is Russell Cole. I'm a family physician also. I'm actually the speaker of the Congress of Delegates for the AAFP, but my clinical practice is actually in Kansas City. I work with a group called Care Beyond the Boulevard doing street medicine, doing outreach into homeless encampments around the Kansas City metro area on both the Missouri and Kansas side. And then I'm also the chief medical officer for the Medicare Quality Improvement Organization for the Southern United States. So that's all interesting, but the question is, okay, so what does that have anything to do with artificial intelligence? And so by way of background on that, I started off in a rural solo practice, integrating EHRs that actually in our small area in Oklahoma, I was one of the first EHR adopters in the state. And we actually got it to where everywhere within 60 miles was on a single EHR. And this was, it pains me to say the turn of the century, which was, 2000 to 2010 in the early days of EHR. And I've just continued to play with a whole lot of different technologies. There is a course that is put on through MIT on artificial intelligence in healthcare. And so I attended that and have tried to just take a very practical perspective of it. While I do have a degree in engineering and some degree of background there, I think it's important to not lose sight of the practical aspect of it. And so that's what led me to think of it as really thinking of artificial intelligence more as just our newest teammate. How is it a tool that we can work with in family medicine? And what does it actually mean for us as we're moving forward? So I'll try to keep an eye on the chat. Feel free to put anything in there and I will do my best to answer those in real time. Let's see if I can get this to go. All right. So I did spend a stint in academia, so you have to have learning objectives. So my thought of what made a whole lot of sense was to walk away with this was 4 things. So think a little bit about just the history of technology in medicine. Artificial intelligence is not the first electronic technology or the first technology that we've implemented in medicine. And so try to take some learnings of other things that we have dealt with in the past. Understand the technological basis of how artificial intelligence works. I think there's a whole lot of hype right now, and it's not nearly as frightening once you understand how artificial intelligence works. And I think that's really a key aspect. And that leads you right into once you understand how it works, you can start to see some of the limitations, the things that people misunderstand about it, and just some of the outright myths that exist. Because we're all looking for the computer system out of Star Trek, as opposed to what we have in artificial intelligence right now. And then finally, the practical aspect is, so what does any of this mean? How are we going to use this in family medicine? What does this mean to our patients? What does it mean to our practice? And so I'll talk a little bit about some of the experiences that I've had with it in my practice in Kansas City. So I find it useful to always kind of recenter yourself that, any sufficiently advanced technology is indistinguishable from magic. This is just an advanced technology. And so you hear a whole lot of discussion and framing that sounds a whole lot like we're talking about magic. It's not magic, it is math. Now, I happen to think math is somewhat magical, but there are a whole lot of people in the world who disagree with me about how magical mathematics is. But that's ultimately what artificial intelligence is. If we step back and think about the broader picture of technology, before 1440, your medical textbook had to be handwritten by somebody. And so that greatly limited the sharing of knowledge. We take all of these things for granted. The idea of anesthesia, we're not quite to 200 years of even using anesthesia. When we get to things like penicillin, we're not 100 years away from the start in that technology. It amazes me sometimes to think back about things that we take completely for granted, like the MRI, which I am older than. A lot of the technologies that are in our everyday practice are actually relatively new. And it doesn't take that long for a technology, when we understand how to use the tool and how it makes sense in the practice of medicine, for it to become integrated. And that's really where I think artificial intelligence is headed. Now, I try really hard to never read slides to people. However, the next slide is like the one slide that I will read to you, just because it is one of my favorite statements ever out of a medical journal. And so the statement was, I have no doubt whatsoever from my own experience of its value, that it will be acknowledged to be one of the greatest discoveries in medicine by all those who are of a temper and in circumstances that will enable them to give it a fair trial. That it will ever come into general use, notwithstanding its value, I am extremely doubtful, because its beneficial application requires much time and gives a good deal of trouble, both to the patient and the practitioner, and because its whole hue and character is foreign and opposed to all of our habits and associations. It must be confessed, there's something even ludicrous in the picture of a grave physician formally listening through a long tube applied to a patient's thorax, as if the disease within were a living being that could communicate its condition to the senses without. The tool that we most take for granted, and which has become the symbol of our profession, the stethoscope, in 1821 had a very nice article written about, it's a really interesting technology, but no one will ever use it because it's not how we practice medicine. I think that probably when we look down the road, artificial intelligence is going to fall into a very similar sort of descriptor from the folks who come after us. So I've used the phrase artificial intelligence, but I really think it's important to step back, and we'll talk a little bit about the underlying math of it. But most folks right now, when they're talking about artificial intelligence, they're actually talking about a GPT, Chat GPT. Well, the GPT actually stands for something. It stands for a generative pre-trained transformer. We'll talk about how it goes through generating and how it goes through transforming. But what a GPT actually does is it is generating words based on how it was pre-trained. And what it is doing is it is actually transforming an equation into words. One of the more entertaining discussions I have with folks. Sorry, I never expected Harleys outside of the Starbucks. So one of the more entertaining discussions that we have, and we'll talk a little bit more about it, is the idea of hallucinations. Well, a GPT can't actually do that. We'll talk a little bit about what it really means, but a GPT is never actually wrong. The problem is we think what we're saying to it means something, and it doesn't mean a thing to the computer. The computer is simply doing math. So let's think about how that actually works and what is the math behind it. So long story short, we'll compress this down. I take something, I put it into a large table. I have a variable that I choose. So I have 400 rows in this table, and each row is a patient. And in the columns, I have 100 columns of every known variable that I have about this patient. And I pick which column that I want to test against. And so I say, okay, well, in column 1, I want to know what predicts yes versus no in these patients. And then everybody remember the wonderful correlation coefficients from basic statistics? The next step is it runs correlation coefficients for every possible variable. Now, the interesting thing about it is, so you have linear classifiers where it gets really easy. And you and I can do this. If the math just is a straight line and everybody above this line is yes, everybody below this line is no, that's not hard. We can easily understand that. And you can explain it. Where it starts to get hard and why it requires the computing capability is because there are very, very complex classifiers. So it's not that I can draw a line. It's that, okay, this area over here, this variable plus this variable, when I add the two of them together, that has a huge correlation. And so what we actually do within the computer programming then is we take each of those and create one layer. So the way to think of it is think of the statement, the dog ran over the hill. First, we do a calculation for the correlation of the. And then we do one for the words the dog. And then the dog ran. And then the dog ran over. The dog ran over the dog ran over the hill. And then we drop the at the beginning and just keep running multiple layers of analyses. And the goal is that the computer will ultimately be able to predict what comes next. Now, this is where training is the huge issue. And I think this is the undiscussed portion of a whole lot of artificial intelligence in healthcare. It will answer based on how it was trained. So if I train it using data that is wrong, it will give me the wrong data in the future. If I use data that is biased, it will give me the same bias in the future. We'll talk a little bit when we get into myths and misperceptions about how you can control for that, but that is a very real risk. And that risk is not in the math. It's not in the actual GPT or AI machine learning aspect of it. It's in the selection of the data that we train it on. And that is probably the most critical aspect to realize about artificial intelligence is an AI is only as smart as the information that it was trained on. And so that becomes a huge issue for us within medicine as we try to figure out how do we apply it. So you can already tell that I like math a little bit, but one of the things that I find really a useful thought process, and I mentioned it earlier. So a GPT is never wrong. It's just answering a completely different question than you think you asked it. And so think of it a bit as speaking with John Nash. So John Nash is the famous mathematician. If you don't recognize him from his actual picture, maybe from the movie A Beautiful Mind. The trick is he will give you an incredible answer. It may or may not exist in reality, but in his mind, it is completely realistic. So what that means, and to think of this in the simplest of fashion, all a GPT is ever doing is telling you what the statistically most likely next word in this string of words is. The problem is you've asked it a question, and in your question, you have meaning and thoughts and biases and what you're expecting and what you're trying to relate to it. The computer doesn't understand any of those. All it sees is the order of the words that you have put out, and it is now using every other word it's ever read, every paragraph it's ever read, to try and predict what should be the next word in this sentence. And once you start to think about it from that perspective, it begins to make sense why one of the most important things when you're using a GPT is to have a really sophisticated question. You want to be incredibly detailed in your question, not because you're trying to get a more complex answer necessarily, you're trying to get a more correct answer. Because by adding in all of the words that you think are related to it, you're increasing the odds that the next word it generates is actually going to answer the question that you're trying to ask of the system. So some of the myths that we run across inside it is, first off, the idea that you can actually just like buy an AI system, turn it on, and go to work. So a GPT like ChatGPT, that's somewhat true. However, only very, very somewhat, because it has been trained to do a specific thing. And the problem that we talked about earlier around training, for example, if you have an AI system that is trained in Boston. So let's say, Harvard Medical School has created a lovely artificial intelligence tool to help you with the management of your diabetics. And so it's going to look at all the data, it's going to ask them a few questions, and then it's going to tell you everything you should do. The challenge is there are a couple of biases in that training data set. One of those is that it's Harvard Medical School, so they don't even have a family medicine department. So that's a whole separate discussion of why they're irritating. But we know that the practice of medicine is different geographically. We know that the patient population at the Harvard Medical School in downtown Boston is probably a little bit different than the patient population that I have in Belton, Missouri. And we know that the insurance payers and what drugs they're actually going to authorize are going to be different. All of those things are going to be baked into the algorithm because it was trained on that population. And so that means one of the things that's important for us is as you buy something or use any sort of an AI solution in healthcare, the very, very first question you've got to ask is, how was it trained and what was the population it was trained on? Now, the other thing that you'll hear a whole lot of is, well, AI is this big giant black box. And because of this black box, it can tell us all sorts of things. And it can be, a hideously racist answer because it was trained based on biased information. So if you just let artificial intelligence run the world, that is a distinctly possible outcome. However, a really cool aspect of it is within healthcare, we almost don't allow right now any of the AIs that operate in a true black box fashion. So the AI has to tell us what algorithm it's using. And one of the interesting things that you can do with that is you can get it to give you what weighting it's putting on each factor. So think about that chart we had earlier where I mentioned, hundreds of rows of patients and hundreds of columns of variables. It's going to set a weight for each variable, and it's going to set a weight for each combination of variables. Where that becomes really useful for us is if we look at it and go, wait, that doesn't make any physiologic sense. That's got to be a systemic racism or an organizational confounder. You can actually go into the AI algorithm and refuse to let it look at that variable. and say, no, we're not going to do this. You need to remove this from the equation and recalculate. So the interesting aspect is, while yes, if you just accept it as is, you can get a whole lot of hidden biases. The fascinating and where I think a lot of the value comes is you can actually find out where those biases are, and then you can start to correct for them by recognizing what the actual influence is of those variables. And that kind of goes to that black box discussion. You can kind of see already from our discussion about how it works, about AI being more accurate than human diagnosis. Okay, there are a handful of places where that is currently true, and it creates a really interesting problem. The places where that's currently true are largely in pathology and radiology, because it is a pure pattern recognition. When it looks at 10,000 images or 100,000 images, and it gets trained on how to recognize, a different sort of cancer, it gets really, really good at it. If you want to make an AI just like smoke and make noise, give it a female of reproductive pain with an upset stomach. Because each one of you can think of about 150 things, some of which have no physiologic basis at all, that could be causing that. And the computer can't yet figure out how to deal with those diagnoses. Now, the thing that I brought up about pathology and radiology that I find really fascinating, and it's not a problem yet, but it's a problem we'll be talking about 10 years in the future, is right now we say the gold standard is a trained radiologist. So if the AI reads this CT scan and gives its its assumption of what it believes it is, then we check that against a person. Well, 10 years from now, if all of the radiologists have been using the AI to start off with and haven't been reading the CT scans themselves perfectly, we may actually lose our gold standard ability. And so the definition of what is the gold standard for a diagnostic test could change dramatically. And this is an area where, like I said, it's not so much our specialty, except for the fact that I am of the firm belief that family docs essentially decide the quality of all the specialties, because we decide who we're going to send our patients to. And so as we look at that and start to think about it, that's going to drive some really interesting dynamics in the future that are not about the technology, but simply about how we use the technology. Let's see. All right. So we've talked about the technology itself. How does the math work? What are some ways that it could be good and could be bad? Let's step back and think about, okay, so if I'm dealing with pure mathematical calculations, what is that really good for? What can AI actually be really good at? Man, it is great at genetics. It is great at taking my my Garmin watch and telling me everything about what what did my heart rate do when I was walking. How is that different at 2 a.m. versus 6 a.m. versus 4 p.m.? It can take all of those variables and create those big things. It's outstanding at image analysis simply because it can view more than a human can. I mean, the computer takes a split second to pixelate and then analyze an image, and it can do that 24 hours a day, 7 days a week. At some point, a radiology resident needs to go to the bathroom. At some point, their brain gets full and tired. And so simply just the numbers of images and the number of things that you can train it on are great. Chart reviews are an interesting area. So NLP is natural language processing. So if you've dealt with any of this, actually, I have a division at work that is working on this right now. So we get in charts to review. Amazingly, a whole lot of them still come in through fax machines, because I think that medicine is single-handedly keeping fax machines working. But to be fair, we did the same thing for pagers for at least a decade, when even drug dealers didn't use pagers, but we still did. But you can take in this fax. You can then do an optical character recognition on it. So we convert that image back into letters and words, and then we have the computer read all of the letters and words. And if we have trained it appropriately, what we can get it to do is find things. And so I actually did use an AI system as a trial that was able to do this. I have, and I'm not endorsing any particular product, but I use Athena, the cloud-based EHR. And the AI tool that I was using actually had an interface with Athena. And so what it was able to do was, as I was seeing a patient, I could say, the name of the tool was Suki. I say, hey, Suki, has this patient ever had a mammogram? And ordinarily, you or I would go and, okay, well, let's click on test results. Okay, I don't see any test results there. Oh, wait, I've got this whole area of stuff that's just been scanned in from their old chart, or stuff that was just kept as images. So the AI system was able to analyze all of those images. And so if they got their mammogram somewhere else, so I didn't have an order in my system for it, I didn't have a lab result for it, I just had a picture of a mammogram report that had been faxed in to me at some point in the past, it was able to actually review all of that material and then pull it forward and tell me, oh yeah, here's where it is. Optimizing schedules is another area that I think is really fascinating. I've only seen one group actually use this right now. And this is not about necessarily the clinic, although it could be. The group that I was working with was actually a small hospital in rural Texas that had a lot of problems with staffing. And there were different generational expectations about how long they ought to work and when their shifts ought to be and all those sorts of things. And so what they actually did was they did an experiment, and they created a survey with basically 34 questions and gave it to all of their nursing staff. And the questions were things like, what time would you like to come to work? How many patients do you feel like you're comfortable taking care of? How long do you want your shift to be? What days of the week do you like to work or not like to work? When would you absolutely not be available? What do you think about different holidays? And so it was 30 questions along those lines. And then they built a handful of rules that said, okay, this is our med surge floor. At any given time, we need to have this many RNs on. We need to have this many LPNs, this many assistants or aides. Give me the most optimized schedule. And the fascinating thing was it came up with what seemed to be the weirdest schedule possible, because no more did you have shifts. If it turns out there's somebody who didn't really want to start work until about 9 o'clock, and there was somebody else who wanted to come in at like 9 o'clock at night and leave at 9 the next morning, it just paired those two people up and put them next to each other. And so at any given time, the staff, it wasn't a matter of shifts, it was a matter of rolling staffing based upon optimizing the day, the time, the number of patients, all those sorts of things. And while that was really interesting, the thing that I found the most useful, if you have ever attempted to deal with a sick charge nurse, like, okay, the charge nurse can't come in today, somebody figure this out. There tends to be just a list of, like, well, they will always come if we call them, so let's just call this person. What they were able to do with this system was they actually could tell you in order, how close is this to complying with anybody's preferences? And so it could give you the ordered list of who you ought to call because they're most likely to agree with this. So it was a really interesting use of artificial intelligence, not a clinical use, but yet a use that had huge implications for how we actually practice medicine. So we talked a little bit about GPTs, and this is probably the tool that is most readily available to most everybody right now. You can certainly go to ChatGPT and make an account. It scored much higher on the USMLE than I did. However, I do not trust it for clinical medicine yet. However, there are a lot of things it is really good at. An example of those is letter templates. Now, if you've been in practice for very long, you probably have a bunch of different letter templates, but it's very interesting. You can go into the Chat GPT and say, hey, give me a templated letter for young women who are due for a pap smear, or for a patient who has a positive high risk HPV, but an otherwise normal pap smear and is a smoker. And it will create some really great patient education material. One of my favorite things about it is you can then look and go, make it dumber, or make it smarter, or make it to where it is written on a 5th grade level, make it written on a college junior level, and it will adjust it. If you just want pure entertainment value, you can tell it, write it like a pirate, and it will come back and it will convert it to all of that. Being from Oklahoma, I occasionally tell it to write it like a cowboy just for the entertainment value. There's nothing like a patient letter that starts off with, howdy, partner, your HPV is bad. But that's a whole separate issue. So you might not actually want to send those letters, but sometimes it's worthwhile. So you got the letter templates, the education. Once we got up to GPT-4, you can actually take a data table, upload it into it, and say, give me an analysis of this data. What does this data mean? Now, I would caution you, everything you upload into ChatGPT stays there. It is there to be used as a learning for the system. So it's continuously learning, continuously improving itself. That means under no circumstances whatsoever do you ever want to come anywhere near putting actual patient information in without it being highly, highly de-identified and that. But where it is really valuable is you can put in information around quality measures, those sorts of things, and look at differences across same or different physicians in the same practice, different measures, different floors of a hospital, all of those sorts of things. Now, this is a free one. You do have to create a login for it. It's consensus.app. Remember earlier when we talked about one of the big challenges of the GPT is what is it trained on? So consensus.app was trained and is only allowed to use basically PubMed. It is peer-reviewed literature only. The nice thing about it is when it gives you stuff, it will also give you the PubMed references. So you can go pull the chart or go pull the journal and look at it and validate, okay, yeah, this is real. This is not something that it just made up. One of the most famous cases, and it's not in medicine, it's actually in law, of a GPT just making stuff up was actually in the legal profession. So it would create, and actually a couple of lawyers in New York were disbarred because they were turning in legal briefs. And it turns out that it had just completely made up the law cases that it was citing in these legal briefs. My personal favorite is the way they got caught was it kept repeatedly citing, I think it was the state of Alabama versus Gambino, which is the plot from My Cousin Vinny, because the computer had been trained on the internet. And so it didn't realize that that was not an actual legal case. And so it was citing all this sort of stuff. So the nice thing about Consensus app is if it gives you a reference, you can link straight in and go, okay, yeah, this is a real article. Here's what it really said. Mixo is another kind of an interesting one. If you're on this, you probably already have a website or have the ability to create one. But if you ever just want to mess around and see a website created in about 45 seconds, that will hurt your feelings. If you're someone who has had to build a website in the past, go to Mixo, completely free. You just say, build me a website for, well, my son did this as an entertainment. They have this game called Water Assassins for the seniors at their high school where they all take water guns and attack each other. So he went into Mixo and said, make me a website for a high school water gun assassin game to sell information about your other classmates. And in 30 seconds, it was a very professional looking website. So that's another tool that just kind of exists that's worth knowing about. Now, this is one that I had it create just specifically for this. With GPT-4, you're now able to get images. So the prompt that I gave it was create a nostalgic image of an early 1900s physician's office, but include modern technologies. And so this is the picture that it generated in about 30 seconds, which to me is really impressive. I am not at all artistically inclined. But you can use it to develop things like that. And we'll see some other examples of those as we go along. I took that, said, okay, well, make that into a PowerPoint background. And you'll notice it just completely redesigned the whole thing, but it made me a really nice PowerPoint background. If you have to give presentations to groups or that, it can create a whole lot of graphics for you really well. The nice thing about it is there's not intellectual property or copyright or any of those sorts of things associated with them because of the fact that they are just basically a new generated image by a computer, which the courts have already ruled actually can't have a copyright or a trademark. So the irony is all of the pictures in my presentation so far have been generated by ChatGPT. So you can see here, these are the different prompts that I gave it for each of the pictures. And you can see the picture that it actually generated as a result of it. So at least to me, like I said, as a very non-artistically inclined, much more mathematically inclined person, fairly amazing. Now, I will tell you, if you play with it a little bit, it has a whole lot of quirks about the way it draws the world, sees the world, and particularly the way that it attempts to use letters in images. So we've talked a whole lot about kind of the technology, some of the pros, some of the cons, where it might be good. You know, the real question, though, is, so what's the future of all of this in medicine? You might have gathered earlier, I'm a big Star Trek fan. One of my favorite things about Star Trek, as you will notice, in Star Trek, the family physicians rule the world because not only do they deal with all ages of patients, all different diagnoses, but they go across species and all of this sort of stuff. And so you will never convince me that the docs on Star Trek were not all family physicians. So how are we getting closer to the tricorder Star Trek future based on the use of AI? And so I would start off by saying, we're not the ones who need to be nervous about this. There are folks who probably should be a little bit nervous about this technology and where it's going. Neurology should probably be fairly nervous. Those specialties where there's a whole lot of diagnosis of very specific things, that is a real challenge. If it is a straightforward diagnostic specialty like dermatology or radiology or pathology, those are all going to be massively impacted by artificial intelligence. Now, think about it like cardiology. You know, the face of cardiology has really changed over the past 20 years. And the amount of cardiologists that are interventionalists, and that's where their practice really focuses, is something that we're likely to see around dermatology and radiology and those sorts of areas too, because the pure think through and diagnose part is pretty straightforward in those. It's just a matter of having that skill. Now, what this means for us, though, in family medicine is some of the things that right now we have to refer won't be referred in the future. I'm not sure what this lesion is. Tell me. I would expect 10 years from now is not something that a family physician would ever ask a dermatologist for. They would pull out probably their next generation of an iPhone, take a picture of it. It'll tell you exactly what it is and what should be done about it. And whether you do the shave, the elliptical, or you refer them for, a Mohs surgery or something like that, that's where the physician discretion part comes in, not on recognizing, was this a bad looking thing or not. Mental health is another one that's on here. And I want to talk about that for a second, because that's a fascinating finding. It's not that mental health is if then, like a lot of the other specialties that are involved. What was a fascinating finding about 2 years ago was they used an artificial intelligence. Actually, it was just a chat bot with an avatar, and they let the patient design their avatar. So you define what you want your counselor / psychologist to look like, and you define what kind of accent you want them to have, and you define what language, and you define all the customized things. And then it was purely just designed to reflect back. It didn't give a diagnosis. It didn't give answers. It didn't try to fix anything. It just tried to do guided reflections, basically, is all the chatbot was trained to do. The fascinating thing was millennials and younger much preferred that avatar chatbot than they did to an in-person mental health provider. I think that has huge implications for us to understand. And one of the statements that was made when they were doing the analysis of, well, why? Well, why is this what you prefer? The answer was with another human, no matter how clinically objective they tried to be, they said, well, I'm talking to another person and that's embarrassing, or I feel judged, or I feel this or that. And they didn't have that concern whatsoever about the computer, which is truly a fascinating generational comment, but it's one that we really need to think about. The other thing that when I'm talking to medical students or residents about is the other people who should be dramatically nervous about this are nurse practitioners. If the basis of your education and your practice is if then, if it is recognition and then application of a protocol, the computer can do that way better than a human can, and can be actually far more precise on the protocol. So I think that's another area of folks that probably should be a little bit nervous and watching where this goes. Now, I just throw this in because I find this a really useful way of framing the use of technology and how we assist physicians. So this is an OODA loop, if you're familiar with it at all or not familiar. If you're not familiar, it was created by Colonel John Boyd, who was actually an Air Force fighter pilot. It was designed to understand who wins dogfights. He was convinced that there had to be a scientific explanation for air-to-air combat. And so ultimately what he came up with through studying tons of gun camera footage and all those sorts of things was the OODA loop. And ultimately what it really boils down to is that anytime you're going to do something, the first step is you have to observe the situation. Observe what is going on around you. Then you have to orient it to some sort of a mental model to make sense out of it. So I see these things, but that doesn't mean anything until I have something in my head that I can orient it against. It's just a picture. Once I've got it oriented, now I have a mental model of what's going on. I'm going to decide, and then I have to actually take physical action. If you think about this, this is why most clinical decision support just pisses doctors off. Because in an intelligent place, that would be between observe and orient. I've observed what's going on with this patient. I want to give them a medicine. If you want to tell me what's on their formulary, I need to know that as I'm deciding what drug. If you want to make me mad, let me pick which drug I think I want. I have oriented, I've decided, I've acted, and then after the action, come back and tell me that I'm wrong and I have to do something different. So this is where AI is going to be actually really useful. Not so much necessarily in the decision or the action phase, but really in the orientation phase. How do we take all of the information that we have about a patient and orient it into something that's actually useful for the physician to have? I think of it sometimes as the difference between a new patient and a patient I've taken care of for 10 or 15 years. If I've taken care of somebody for a long time, there's a whole lot of variables I'm not actually actively thinking about, but I'm taking into account as I'm making this decision about how to deal with this person and how to help them. What AI has the ability to do is to help me jumpstart that, help me get that amount of information about a patient way earlier than I ever would have in the past. So if we think about it from that perspective, what are the different steps of the OODA loop where we might actually use AI? How does it become a teammate as opposed to just a technology that we try to apply to everything? Well, if we think about it from the observation phase, that Internet of Things data summary is incredible. I will admit, because of my patient population, I don't generally get to use continuous glucose monitors. However, my mother-in-law has been a diabetic for quite some time, and she got a continuous glucose monitor. And oh dear God, that is the coolest thing I've ever played with. Her hemoglobin A1C said she was great before, but it turns out that's because 250 and 50 average out to good, as opposed to swinging from critical to critical to critical all day long and just not knowing about it. That continuous data actually let us refine her treatment and get her in a much better position where she feels a whole lot better. The problem is that's more information than we as doctors can deal with. Think about all the things that are measuring what your patients do, their activity level. We've got basically continuous cardiology monitors on everybody wearing an Apple Watch now. We've got pulse oxes on patients who are wearing their Apple Watch. How am I going to deal with all this information? Well, AI is a great way to do that because it can give me a data summary. What's actually important here? And we talked a little bit about the idea of using it for skin lesions. Hey, how do I see this better? How can I see where the edges are? And this is particularly valuable, and it's particularly a hard aspect of dermatology around pigmented skin. And part of that is because there are so few effective pictures to be able to train it on. Go to most of your dermatology books, and most of the skin they show it on is, relatively non-pigmented Caucasian skin. The AI can't necessarily translate that to a greater pigmentation. Already talked a little bit about the idea of prior auth and formulary, how all that works. Genomic responses. I don't know if you guys have patients who walk in with their 23andMe report that says, oh, here's the medicines I can and can't take and how effective they will be. That's great. I just don't know how to apply all of that information to a patient. And as we find new things, I need something that's going to help me translate all of this for the patient. I think that's another great use for it. Intervention impact ranking. So this is probably the more controversial aspect of it. I had a professor in medical school who I loved and had him in residency also. And he was very fond of saying, whenever you reduce a patient's risk of dying of something, all you're actually doing is increasing their risk of dying of something else. Because they are going to die ultimately. You're just picking which one. And the fascinating thing about that is when you step back and are able to actually start looking at all the things that are affecting this person and what are the known impacts of all the possible interventions I could do. One of my favorite things to do with the residents was to limit them. You can only give somebody 4 medicines because, dear God, they're not going to take more than that anyways. Now, we would then go ahead and prescribe all the different stuff in that. But by going through the academic thought of what are the 4 most important medicines that you can give this patient, that was kind of the start of how do I decide in a patient who can't do everything, how do I get the biggest impact for the things that I am going to do with them? That's going to be a challenge for us in medicine because for so long we've looked and said, oh, well, your blood pressure systolic is 142. So here's your HCTZ. Awesome. That is probably not what was going to kill them. That's what works at a population level. But as we're able to start to drive the risk factors down to the individual level, the way that we treat patients actually has to change. That's been impossible to do with any sort of measurable accuracy until we started to get to the artificial intelligence. So question here about, as an educator at a med school, what should I do to prepare for ongoing changes from AI? Any ways to catch up with updated resource material helpful for educators? Consensus is a great place to start. The funny thing to me is what we're seeing in undergraduate education is a return to oral exams. If you have somebody write something, yeah, but if they actually have to sit in front of you and explain something, that's a whole different thing. I think from a medical education perspective, we're probably a little bit better off because, well, good Lord, you can't hardly fake your clinicals. You're either doing it and doing well or you're not. So I think the other thing that I would really throw out as where I would be going with particularly working with medical students or residents about artificial intelligence is I would have them go ask it. I would have them use the tool and use it as a way of testing their ability. It's gonna sound bad. A way of their ability to recognize BS. Because the best way I have heard ChatGPT described is it is a really confident moron. It will give you, and it will sound exactly perfect unless you have any idea what you're talking about. And then you read it and you go, well, this isn't right at all. Why I think that's valuable for medical students is because I think that the ability to counter medical misinformation is going to be a growing part of what it is that we do as primary care physicians. And I think a lot of that medical misinformation is going to come from AI GPTs. And so being able to think of it from that perspective, I think is a really important aspect for them. So I'll show you real quick. This is a 30-second, it took 30 seconds to create this. So that's the original. This is what 30 seconds of a $2 deep fake. So not even a really fancy good one.
I'm sorry. Maybe just me, but I couldn't hear.
It may not have come through on the audio, but the thing you can see here and what's so amazing about this as a deep fake is there wasn't a video. I downloaded my picture off the AAFP website, and downloading that picture, I put it in and said, apply it to this. It's making all the facial gestures, all of the movements and that sort of stuff. Now, that's not a great deep fake. I mean, you can obviously tell, okay, that's not real. But I think the important part is, like I said, this was $2 and took 30 seconds to create. Imagine what this is going to look like when you actually get good technology and high processing speeds behind it. So I told you earlier, you can use it to create things, but it's really bad at words. I asked it to make me a poster promoting the Missouri Academy of Family Physicians and make it Missouri specific. And this is what it created. So it does pretty good at images. I'm not really sure what edpocation is. Networking opportunities. Like I said, words are not its strong suit when it gets to images, but you can create some really interesting things. And so, this has some value if you think about it, just of, oh, I need a background image or that. If I put my words over the top of it, knowing what it should be, you can make actually something really cool. So with that, we're coming up on just the end of the time. I've run pretty fast, had just kind of the one question. I want to stop and open it up to anybody else for any questions, any thoughts. And once again, I apologize for the Harley. There was a Subaru with a really loud exhaust pipe, but hopefully the information came through pretty well. So let me stop there for a moment and open it up to any questions or thoughts. Jane, I see your hand there.
Thank you. Thank you so much for your lecture. I really love it. And how all of this was, of course, it was scary in the beginning, how AI is taking over a lot of the things we were doing in our process. But one of the comments I was going to give, it was interesting when you typed out a family physician, a picture, it showed an Asian female, which is interesting how that came about. But my question is, with your work on Care Beyond the Boulevard, I'm a family physician in Kansas City. I work with St. Luke's and currently medical director for health equity and diversity. So a lot of our work is focused now towards piloting a lot of our AI. I'm part of a pilot right now where it's your visit is, it's called ambient AI. Your visit is going to be incorporated in your note. And so what we've noticed is sometimes it doesn't generate the proper pronouns of patients that are coming in with their gender identity. It doesn't always capture on what our chart was showing. But the main comment was, or question is, how do you see that applying with our street medicine, how it can help us determine risk factors for our patients with high risk in their social drivers of health?
Yeah, that's a great question. I actually tested out an ambient AI system with street medicine, and it was hideous. So that being said, when I went to the clinic, it was great. When I was under Sterling Bridge on I-70, and the patient was talking, 80% slang and was a flagrantly psychotic schizophrenic, the AI could not determine whether or not there were actually dragons around or what was going on. So that's it's interesting that you bring it up. It was really cool, but it's just not there yet. So I think that the greatest value in my mind is we're still very early on, but what it's good at is identifying correlations that I never picked up before. Looking at, as humans, we're good. If I get one variable or maybe two variables, I can look at those and go, okay, well, here's what's likely to happen. Letting it look through the entire chart and give me, okay, when these 5 variables hit, 98% of the time, here's what happens. And there's no way I would ever have the time to do the chart reviews and come up with that. That's where I find it really valuable. And I think it does allow us to get to the things you were describing that are the variables that we maybe haven't ever thought of. I'm fascinated about the application of pronouns, because that's one that, I don't even know how you would train the computer to do it yet. But those are great comments. I really appreciate it.
Thank you.
Anybody else with any questions or thoughts?
Hi, this is Kento Sonoda. I put on the comment on the chat, but let me say that too. But as an educator, like at the medical school, like what do you recommend us to prepare for ongoing changes from AI, and any ways to catch up with updated resources, like helpful for educators? Thank you.
Yeah, so catch up is a hard phrase because it's you don't necessarily have to learn everything that's been done before, because you can skip a whole lot of it, because a lot of it was just proving things that didn't work. What I would say of how do you get fluent on it quickly? How do you apply the information? What I would really encourage you to do, the AAFP, we actually put out, it's been at least 6 months now, a series of principles about the use of artificial intelligence in healthcare. Start with those. You can go to the AAFP website, you can pull them up there, because what I think that does is, if you demystify it, say, look, this is just a tool. I am just giving you a tool to look at something. Once you understand it as a tool, that's great, but you still need to know what the rules are about how to use that tool. And if you can instill in students, residents, and those principles about, okay, here's what's important about the use of artificial intelligence, here's how you do it right, I think that's probably the area that I would start off with. Don't get so enamored with the technology. Focus on the use thereof, because that's what the students will actually be doing down the road.
Thank you.
All right. Well, we're at the end of the time, so I certainly appreciate everybody joining this evening. You know, I hope what you walk away with is a little less fear, a little understanding about, all right, this is just applied statistics. There are some areas where this could be really useful, but the reality is the solution will not come from people in the technology industry. They will create super cool tools that they have no idea how to use. I think the most important aspect of this is for generalists, general surgeons, family physicians, and that to get involved and make sure that what they're building tools to do actually make the lives of our patients better. I think there's lots of ways that we can use this. Don't be afraid to use it. I have found it very rewarding and very interesting. As I said earlier, it has opened up insights that I never would have made on my own. And I think our goal as family physicians is always to do a better job tomorrow than we did today at making our patients' lives better. And this is giving us a way to look at our patients and understand them in a different way than we've been able to, based on just the charts that the EHR has given us over the last few decades. So hopefully you come away with it with a little bit of optimism, a little bit of skepticism about some of the claims, but a recognition that this can be actually a really valuable tool for us in the future if we guide the development of it correctly. So with that, thank you very much. I appreciate it.
Thank you very much, Dr.